TopMedTalk.
Well, hello and welcome to TopMedTalk. I'm Desiree Chappell, your host, managing editor of TopMedTalk. And guess what? TopMedTalk is back at it. We are here at the first ever solo ERAS Cardiac Society meeting in Houston, Texas. Guys, I'm on the road. This is craziness. We've all been vaccinated, by the way. We've all been wearing our masks. We're here actually doing a virtual conference. So I think we have about 12 people that have been in and out of rooms. We've been socially distancing, but we've been putting on a virtual conference here in Houston for the ERAS Cardiac Society. Now, I know it's crazy to think that we're back in business, but it's totally different. And I think over the last year or so, we've learned a lot about what we can do through Zoom. But I have to tell you, it's so nice to be in person and to actually have some human interaction in person. Unfortunately, though, restrictions have not lifted yet for international travel. So my co-pilot, my partner in crime, Monty Mythen, is still over in London. And as I'm recording this at about 5 o'clock at night, he is probably in bed or celebrating his birthday. So happy birthday, Monty. But fortunately, I've had the chance to chat with some friends of TopMedTalk that we've talked to before. And we are going to have an awesome conversation about ERAS Cardiac here tonight. So I wanted to introduce our guest. We have Gina McConnell. I'm going to let her introduce herself. She's been on TopMedTalk before at the WakeMed ERAS Cardiac meeting back in 2019, Gina. I can't believe it's been that long.
No, too long. We've missed you. So yes, Gina McConnell. I am the ERAS coordinator now at WakeMed in Raleigh, North Carolina. Just took that position a year ago in January. Gosh. That position that we fought for years. We finally were awarded that. So I've been in that position for about a year. I've just always been a cardiac surgery nurse. I worked at Duke for 10 years in their cardiothoracic open heart unit, heart and lung transplant unit. I left Duke and went to WakeMed, and I've been there 15 years. I worked in their CT-ICU and then moved into the supervisor educator role for the past, 7 or 8 years maybe. And then kind of in that role, that's when we learned about ERAS and developed ERAS and moved. And that shifted my role now into this coordinator position.
I want to say that Gina actually brought ERAS to her facility. Yes, you did. Tell us, because what I always love to hear is the fact that, ERAS doesn't have to start with an anesthesia provider or a surgeon.
That's correct. I was lucky enough to have just those great people in place, but it's so simple. I went to a dinner to learn, and I had never heard about enhanced recovery after surgery. Our hospital never did any ERAS pathways, so it was completely new to me. And they continued to talk about every service line except cardiac surgery. They were great outcomes and every other service line, hernia, colorectal, breast, cesarean. And when I raised my hand and said, hey, what about cardiac surgery? He laughed at me and he said, we don't do that here. He said, it's done in the UK, but there's no one in the country that does that. And I was like, well, why is that? And he said, well, there's too many barriers, with cardiac surgery. And I said, wow, has anybody tried that? And he's like, well, I'm sure they've tried, and that was it. That was it. It was not going to happen. And I went back to my hospital and I just had a wonderful manager, wonderful team, wonderful surgeons, and said, hey, have you guys ever heard about this ERAS thing? Just as naive. That's just it. It was just naiveness on my part. And when we started to explore it, it was like, oh my gosh, why wouldn't we do this? This is crazy. And that's when Dr. Williams stepped in. He was a chief fellow at Duke and then came over, was hired at our hospital, and he had learned and trained under the trauma surgery guy, women and men at Duke, and was familiar with ERAS. So when I finally was getting my act together and went to him, and he was like, oh my gosh, yes. And he said it was just the perfect storm, because I had done so much work with our anesthesiologist and our team at that point, and he walked in and he just, was amazing. And we built a team, and,
here you are.
Here we are. Yeah, that was
planets aligned.
They did. And you think we went live with cardiac surgery ERAS 2017, April 4th. That's 4 years ago. And it seems like it just happened, but
Well, I want to kind of get back to that here in just a little bit and just talk about kind of the state of enhanced recovery for you after doing it for that long. But I did want to introduce our next guest. We have Cheryl Crisafi from Baystate Medical. Cheryl, you've actually been on TopMedTalk. I don't know if you've actually known that, but you have, because we put out all the conversations, wonderful conversations that we had during the last EBPOM meetings over the last year. And so we had a great conversation about enhanced recovery and about how to get it started, how to keep it going, and all that good stuff. So welcome back.
Thank you. I'm a coordinator nurse with the cardiac surgery team at Baystate Medical Center in Springfield, Mass. And our journey actually started when another journey ended. We were in a cabbage bundle payment with the Medicare.
Oh, yeah.
And when that bundle was ending, we were wondering, where do we go next? We had worked on so many process for quality improvement, and we were exploring ways that we could improve our patient engagement. That was really our number one focus. And our heart and vascular intensivist, Dr. Daniel Engelman, cardiac surgeon and a hospital intensivist, had stumbled onto a lot of information about enhanced recovery. And we started having discussions, and that was the beginning of our journey. We started with our patient engagement and working on how we could have our patients be well educated about what to expect during their preparation and hospital stay.
Interesting. So your background, were you doing cardiac for a long time? I mean, you're a bedside nurse, and then how did you tell me a little bit more about your journey, about how you were involved?
My journey is I was a bedside nurse for 10 years at a different institution in a CTICU. I was a coordinator nurse for a joint replacement institute for 7 years. I obtained my master's degree as a clinical nurse leader, and that role is really focuses on process improvement and patient engagement, patient education, staff support, and advocating for everybody, really.
Yeah.
So a coordinator nurse role was a great place for me to use the skills I had from my clinical work and new education. And I took the job as a coordinator nurse, and it was really because they were entering into a bundle payment.
Oh, okay. For just CT, right? So
for
not
CT.
Other ERAS.
And at first, the bundle payment was, I was hired as a cabbage bundle coordinator, but it was very quickly apparent that whatever things you do to improve the care for one set of patients really should be for all of your patients. So that lasted about a minute, and I had myself renamed as the cardiac surgery coordinator nurse.
Yeah. That happens very frequently, doesn't it?
Yes.
Your background is, when you were saying those things, I'm like, boy, if you look at a foundation of an enhanced recovery program, I mean, you can do order sets, you can do, all your fancy interventions, but really when it comes down to it, your foundation has to be, that organic education, where you're trying to bring everybody on board and engage them in the process and make sure that the patients know. So it probably felt like a natural fit for you.
Yes, but it's kind of eye-opening when you're trying to pull a team together, to see which people will have buy-in and which people will easily adopt what you're trying to put out there. And even with patients, some patients are want as much information, and they're so engaged with their upcoming surgery. And then there's others that are just very challenging to engage. Yeah. And I think that's human nature. And so that's what we all are trying to help pull the team together and hopefully make a strong team.
Yeah, absolutely. Well, that's a good point. We'll dive into that a little bit as well. So we're at the ERAS cardiac meeting. So far, some of your favorite moments. Gina, I'll start with you.
Oh, wow. I was honored to be invited. And then Dr. Williams and I discussed for weeks upcoming, how awesome to be at the same place again with the experts from across the globe and have the same issues that we're having and the same things that we're trying to figure out, that we can have dialogue. And it's live, it's immediate, it's experts, it's, oh my gosh. I mean, there is nothing that has happened in the last year and a half that has been more rewarding or that I'm more excited about. And I think when you have those opportunities to network with this group of people, what you take back is far more worth its weight than anything else, because our team says every time Dr. Williams and I go away, they're like, we're so excited when you come back because you like blast us, like you're so passionate, but then it overflows into them. So what does that do? That's changing processes. It's changing outcomes. So
Changing culture.
and changing culture. Yes.
Which we all know is tough. Yeah.
Yeah, it's been great.
Good.
Even just through today. Today was amazing.
Yeah. Cheryl, what about you? Any favorite moments that stick out?
So I am very passionate about nutrition. I've always known that nutrition is very important for patients, but I've learned more and more about it as I've learned about ERAS. And one of my idols is Dr. Paul Wischmeyer. And
You're not alone.
He was a speaker today, and I was on this panel discussion with him. So I just felt like it was an absolute pleasure to hear his lecture and to listen to him answer the questions so eloquently that were coming in. And it just spurs me on to really want to even learn more and be more of an advocate for good nutrition.
Oh, I love that. We know Paul he's a fan fave for our TopMedTalk listeners. I'm sure everyone listening now will agree. He is absolutely fantastic. And we've had him at our EBPOM meetings as well. And so there's plenty of lectures on TopMedTalk that you can go and hear Paul. So if you haven't, from the words of Cheryl, it's a must, right?
I signed up for his Instagram.
That's awesome. We love you, Paul. Well, that is so great. Well, some of the interesting topics that I think are coming out of the meeting, one, the nutrition aspect. We're going to be talking about opioids, which I think is always, that's always an issue that we want to, talk about. We talked about brain health today. So that was a good one. Carol Peden, Rakesh Arora, Jacqueline Chang. Those were all fantastic conversations. They're going to be doing some deep dives into some of the technical aspects of things, right? So like the surgeons are really interested in, they had a conversation about the sternal closure, rigid sternal fixation, things like that. So I think it's going to be a great meeting. So if you weren't able to check it out, for all of our listeners, you can always go back and, get that information that is available through the ERAS Cardiac Society on their website. So I would urge everybody to check it out. So some of the things that I want to talk to you guys about while I have the ERAS coordinators in my grip, because this is, you get these conversations a lot and you have providers from all different backgrounds say, how do we do this? How do we do that? Gina, to your point, I love the idea loved what you said about you come back, you get to share all your information and, you feel like you're really making an impact, you're changing. I mean, it really is truly changing culture. Mm-hmm. I think you're really lucky because I think there are some people that come back from meetings like this. Like I'll go back and some of the providers will be like, oh God, Desiree's coming back. Here's some new ideas.
I know. There's those two. Yeah.
So you're really lucky. So tell me a little bit about provider engagement. Like, how are you really seeing that you're getting people excited about this from all different backgrounds, not just nursing? I'm sure you guys are responsible for talking to other surgeons and talking to other, talking to pharmacy, all these different people. Mm-hmm. Gina, what do you think is some of those best, practices to get that going?
We speak about asking providers, no matter at what level, to do more, to do something different, to change processes. This is better for the patients. We want to increase our outcomes. But what we really need to focus on first is building those relationships with them, valuing their piece of the puzzle. And I think, you talk about nutrition that Cheryl spoke with, or our dietitians or our pharmacists, and they are crucial pieces of this. And so we have to engage them just as much as our surgeons and anesthesiologists. And I think what we did with ERAS really well, and I know a lot of hospitals are doing the same, is we put up a united front. We had our team, our surgeon, our anesthesiologist, our nurse, our CRNA, our APP, our pharmacist, and we deliver that information twofold. One, getting everyone's engagement, but showing them that we're in this and we're going to support you and we value you, but we do need to make some changes. And then, so I always joke and say it's a cheerleader role. You really do need to cheer them on that we need you desperately. We can't do it without you, but we also know we can do better. Yeah. And I am fortunate that I have such amazing surgeons and anesthesiologists and intensivists that they are buying in, they are listening when we come back, and they're equally as passionate about it. But they are struggling with the workload and things that have happened this year too. So it's a balance. There's things that are on our to-do list that we have put off for a year. Mm-hmm. And we're no more ahead than the rest of the country in some ways because we've had to balance that. So engagement with our providers and our team, relationship building, honoring and valuing what they are able and capable of doing, and then taking a back step once in a while. And this year was a huge back step. We just had to take a moment, and that's okay. And just reassuring we're just going to pick up where we left off. But it's not something we need to enforce and heavy hand and push forward no matter what at any cost. That's not what we're trying to do. I think our ERAS program will shine when we do that from the very beginning of the people that are building that. And that is what I think we have done very well. And many other hospitals have done very well, building those relationships, building those teams, empowering them. I get excited from learning from you guys. You guys empower me. We're so engaged. And so I want to take that back and then just replicate it, So it's hard this year, but.
One of the conversations that we hear a lot that we always ask the question, is it a carrot or a stick that gets people motivated to do something? So like, is it that you're, like just forcing, or is it like, how do you incentivize? And, for certain providers in the ERAS team, there may be ways to like incentivize, either monetarily or other ways. What about for, nurses? I mean, there's really there's no financial incentive that comes down to a nursing perspective. I mean, Cheryl, do you have any?
I first want to say this year I've been a nurse for 35 years, and without a doubt, this was the most difficult year of my nursing career. And also probably the most eye-opening year. I've been redeployed recently. For the past 6 weeks, I've been working with the team that takes care of our post-op patients on the floor, full-time, redeployed, helping them. And I have a new appreciation for the workload that they carry every day. And when I return to my role on Monday as the coordinator nurse, my priority is going to shift to how do I make their job easier. And I think that is really, they're not looking for a monetary reward. They're just looking for how they can provide fantastic care and do it efficiently. And I'm going to do everything I can to help them execute that. And
I don't know about you guys, but like, do you remember the days that you actually could do patient education? You could spend time at the bedside. I can imagine now with COVID, things are always going to, it's just different, but giving that time where you can go back and spend just a little bit, or like, if you're the one that has to get them up and walking, while you're walking with them, you can take the time to like educate them and talk about some of the things. And that's what I always encouraged our nurses to do. Like, if you have any extra moment, it's just talking and educating.
That's kind of how I put it to the team, whatever team it will be, nurses, respiratory therapists, dietitians, whoever it would be. I kind of say, Cheryl said it perfectly, I'm trying to make your job easier, because if I can standardize the order sets and standardize the pathways, compliance is easy after you can standardize this. What's hard at the bedside is so many expectations and so many different pathways and protocols, and their workload is doubled or tripled, and they're still trying to maintain that. So the deep heart of a nurse is trying to do the best you can, and you start to feel inadequacies. So I say that all the time. I'm like, guys, I know this sounds like I've just educated another floor, a step down floor. And I said, when I walked in, they all rolled their eyes like, here she is again. That's different because they're thinking I'm seeking something from them. My first words are, I'm going to make things easier for you. I'm going to try to implement something that will make it so standard, it's almost going to be hard to mess up. And that's what you guys need. And so then they're like, oh, okay. Oh, let me listen to her then. And in turn, then I go back 6 months later, like Cheryl, we go back. I'm like, look at what you did. Look at our outcomes. Look at this. This was because of you. And Dr. Williams will be the first person to tell you, this is not because of me. This isn't a surgeon driven, although he does amazing work, it's driven by the whole team. And when they hear that, it validates and reinforces. So I agree with Cheryl. I'm trying to make, of course, we want better outcomes for our patients. Absolutely. But I'm really trying to make it easier for the front line.
Yeah. Yeah. For them to do that, because that's how we get them. Yeah. No, I completely. Monty, for a long time, I would call him up and be like, about this ERAS program, like, I'm really trying, but we can't collect all these data points. Like, what are the main things? He's like, it's the standard approach. It's like drinking, eating, and moving for every single ERAS patient, unless you technically have to have someone laying flat because they've just had spine surgery and they're in the between stages or, something like that. They're physically, they're intubated or whatever. It's basically, that's it. That's the basic tenets of it. And if you can do that and make sure that happens, then everything else falls into place. And I really have tried, as I've gone into a new role recently of trying to get, and reinvigorate another ERAS program. It's like, okay, let's just get back to the basics. Mm-hmm. Let's do the things that we know that needs to be done really, really well, standardize that part. And if there's certain nuances, you can do that. Cheryl, I loved what you said about like, let's make your job easier. So are there any things that you're kind of working on to do that?
I've now become the end user of some things I put in place. And I'm like, why didn't anybody tell me this was broken? So I'm a huge fan of videotapes of patient engagement and education. So we made a discharge video for our patients and it's great. We loaded it onto a tablet. Well, nobody told me that the volume on the tablet was hardly audible. And we have a Get Well platform that I'd requested that the video be loaded into. I thought it was there, found out it's not there. So I've, even in the redeployment role, have already been working with the Get Well team to say, how do we get this video into the TV? Because this is a lot of work for me to carry around a portable microphone, a portable speaker for the nurses to let patients listen to this video. So simplifying things like that. There's some issues like I think that we could help with other resources like pharmacists being a little bit more involved with med reconciliation. That really is a big area of importance when you go to do a discharge, that your med rec is in great shape so that you have all the meds correct when you do your discharge. I think that our pharmacists might be able to help out with that a little bit. So I think it's engaging other team members to help with ambulation and things like that. And who can we have? And it may even be me doing some of it because I see that it's a bit of a need. So stepping in and helping on those levels as well.
Yeah, absolutely. For those who are starting a program, or for those of us who have dealt with COVID, and, Gina, you said, like, you're telling me earlier, your COVID or your enhanced recovery program, when you actually went to go look at it after this year of craziness, that things didn't actually look too bad, did it?
No. Yeah. It was absolutely amazing. I kept telling Dr. Williams a year ago when COVID hit, I was like, I'm nervous because, things aren't getting done. The basic drinking, eating, moving, components of ERAS were not getting done. And it's a COVID, it's a year, we're just going to deal with it. And what we realized when we got our data, I was like, oh my goodness, it really hasn't changed. And that speaks to the standardization, that you didn't have to think about it. The compliance continued because it was so standardized. We had a well-oiled machine that just kept on working through COVID. And what better time, what greater need, I guess, is more than now for it going through COVID. We need this. So yeah, we were completely shocked. But
well, I think so. I guess, that was what I was going to ask is, for those who are just starting out or those that have to start over because they took such a step back, because I would imagine that there are probably facilities that didn't have it so ingrained in their culture, so like, what are some of the things that you think, I know you said standardization, but like some concrete things that, we can use as enhanced recovery coordinators or those who are leading in these efforts that they can do?
I think Cheryl and I have talked a lot about that. I'm so fortunate to have her as a peer and be able to discuss what other coordinators are doing, as well as Vicki and Bethany at UVA and so many good people. But what I tell people, even in the last 4 years, is you need to start small and keep it simple. We could talk about ERAS from a month out, they know they need to have surgery. It's a month out. We could really start ERAS in the prehab phase, go all through the perioperative phase, and then 90 days out. That's the goal. That's like the home run, right? That's what we really want for ERAS. But that's not feasible for institutions starting ERAS because along that platform, there's not resources in every one of those areas. I don't have any prehab resources. So my prehab has definitely been put on hold, but I could take them from the minute they stepped in the hospital to the minute they were discharged. And that's what I tell other institutions. Keep it simple. Dive into the resources you have. You have them from post-op day of surgery till post-op day of when they leave. You already have some processes already there. You might have to manipulate them, change the workflow, but you have them there. You can monitor them. They're in your hospital. So keep it simple. Start out with a few components. We start off with ERAS cardiac surgery with, I think, 7 components. Now there's 150. I mean, there's a ginormous amount, right? But it's okay because we perfected those first 7 and then we built upon it. And we had such value in 6 months, just having those few components. We had such amazing outcomes that it just empowered us to do better. So develop a team that is small and pick your team wisely. I always say that. Choose your most passionate and your team players that are going to meet you halfway at the table. Go simple, keep it simple, few components, and roll it out. Teach, educate. When we rolled out cardiac surgery, we educated for 4 months and people thought I was crazy. Mm-hmm. But what that did is allowed me to face-to-face. This was brand new to the hospital. I wanted everyone to know about it. I don't think we need that much time now that we're rolling, but take the time to engage in those people that are going to be rolling it out.
Yeah, no, I think that's great.
Simple.
And then Cheryl, we've talked about this. Data is a huge driver. And we have to get the data. And a lot of people have trouble with that. Let's talk about that a little bit because I know you've done some work there.
I have. And our outcomes nurse has been very
What's
helpful.
An outcomes nurse.
She works for
I want one of those.
The quality department. Uh-huh. So she has a lot of metrics that are hospital-based metrics, and they're based on service lines. And they don't really drill down which patients really followed the ERAS protocols, but they look at your program overall. And working with her to find out which things we could put in a dashboard for our ERAS program has been helpful. So, for example, she was able to pull the information on which patients had received regional anesthesia. So we showed we were at 0% in the fall of, I think it was fall, let's put it this way, over a period of 1 year, our anesthesiologist went from 0 to 80% of our patients having regional anesthesia.
This is for cardiac?
This is for our cardiac surgery patients, 0 to 80%. Wow. And so she was very helpful in helping us look at that information. And we also use our data from our STS database. So that gives us our information like on surgical site infections, readmissions. And so we kind of pull it together from a couple areas that we look at. Very important to our team has been reducing acute kidney injury. So we're always looking at that data to see how we're doing. And would we love to have an ERAS dashboard that shows specifically patients that followed the pathway
to a T,
and their outcomes? That's the dream.
Yeah.
Right now, the reality is we are not quite there to be able to calculate the data on which patients did have 4 walks, who was that person that was sitting on the edge of the bed day of surgery. So we need to get there, but that's the goal. Mm-hmm. And right now we do meet and discuss our outcomes, but it's more of our population outcomes.
Yeah, higher level. And I know, Gina, you said you share it with your teams. Is that something you do too? And
yes.
I think that is it's missed so often that it gets you have all this awesome data, but it gets shared with 6 people.
No.
Or administrative or leadership that, no disrespect, but the front line is who's doing that work. Mm-hmm. They need to see the repercussions of that and how great it is.
Yeah, absolutely. Well, ladies, honestly, I mean, I could talk all night, but we're getting ready to, I think the whole group's going to be here in just a little bit. Thank you for all that you do. We didn't get a chance to talk to you about it too much, but I know both of you were redeployed back onto the front line of nursing and back at the bedside. And though I'm sure it was different, thank you. And I hope that, you, like you said, you were able to take some things back from that experience and back into your roles. So good luck, after this.
No.
And
Thank you, Desiree. You make this so easy, and the work you guys put into this is heard across the country. And just thank you.
Oh, well.
And Monty, happy birthday, Monty.
Thank you. Thank you for, I also want to say thank you for this opportunity. It is fantastic that we're able to get together and discuss the best practices and things that we're all working on.
Yeah, absolutely.
Yeah.
Well, if you guys want to find out more information about the ERAS Cardiac Society, it's erascardiac.org. Yes, erascardiac.org. And you can find them. They're on Twitter and all your favorite social media outlets. So thank you for listening. Everybody be safe. Thanks again for listening. And cheers.
TopMedTalk.
Thanks for listening to TopMedTalk. We are excited to announce the World Congress of Perioperative Medicine happening in London this year. Check it out at ebpom.org. It will take you through to our carbon-free conference center where it has the EBPOM platform. You can find more information. Be sure to subscribe to TopMedTalk and EBPOM at ebpom.org.